Morning, everybody. Thanks for coming and joining us so early. This is a pleasant surprise. We're still trying to get the hang of this, but how are you today, Dr. Dev?
I'm fantabulous. You?
Very good, very good. Thank you
Quick
for joining
question.
us in our live with Dr. Dev. So we really
Of course.
appreciate it. You know, it's so important. Our patients are always asking questions, and everybody's always so nervous about surgery, plastic surgery results during the recovery. So it's really helpful that we take the time to educate the patients and make them feel at ease. So definitely, we really appreciate taking time today. We do have some time today, so it would be really good if everybody just chimes in and asks. So I'm currently hitting the Dr. Okay. Okay, so I'm going to get my glasses. So we can start with just questions that patients contributed. And one of them, especially since we've now added buttock implant removal to the roster of surgery procedures. So that's been pretty interesting. Are you enjoying doing the procedure? One of the patients is asking.
Yeah,
How are you doing?
I love doing them. They are also a technically challenging procedure, just because of the anatomy and the location to nerves and muscles. But the outcomes have been amazing. We have removed probably in the last one, I would say 2 or 3 sets of buttock implants. And I think 3 of those 6 implants were ruptured. 2 of the implants that were in there were breast implants that were placed in the buttocks. So it's similar to the breast. You never know what you're going to find in there.
That's
And
the craziest thing that would even happen.
yeah, I mean, I'm not surprised with the ruptures and the stuff like that because, you're sitting on these implants all the time and a lot of pressure on it. But the patients who want them removed, I don't want them removed because they're just too heavy. With time, everything, just gravity pulls everything down, and they're having pain when they're sitting. They can't sleep
Do you think
on
there'd
their
be
buttocks.
some permanent nerve damage
I
on
don't
the
I
buttock?
don't think it's permanent. It's transient because the implant is pushing on that nerve when you're sitting or you're laying down, so they relieve that pressure. It's like carpal tunnel in the buttocks, constant pressure on a nerve, and they're gonna get numbness and tingling and issues in their lower extremity. So I don't think it's permanent. Definitely. The one patient that we had that had chronic pain and lower extremity numbness and tingling all resolved after we took those implants out, which was amazing to see
Yeah,
her recover. So
I remember her. She had really big implants.
huge implants.
We
I
thought
mean,
she was, yeah, and which was pretty amazing how the skin just kind of retracted and
yeah,
went back to, because I thought she was going to need some sort of extra skin removal or something, and no, she
yeah,
did just fine with the implant removal.
yeah. Sometimes you can do adjunct procedures like skin removal and stuff like that, but I always discourage doing anything like a fat transfer to volumize the buttocks and things of that nature when we're removing the implants and the capsule, just to allow everything to settle, and then you can wait and see how things settle and then do adjunct procedures down the road.
Uh,
Yeah.
Okay, we have a question. Have you had women experience numbness around the nipple, but also pain on the nipple at the same time? If so, does it take away?
Yeah, no, it's a great question. So the nerve to the nipple usually comes from the sides over here. I don't know if you can see, but right from the side of the chest area. And so if that nerve gets affected, I mean, it can be with an implant in there after an explant, but if that nerve gets irritated, you can get numbness in the nerve distribution, and you can also, but there's also collateral nerves that go to the nipple. So some of those nerves can be exaggerated or hypersensitive, and that can lead to pain. So there's multiple reasons. It can not only be nerve related, but it could also be scar tissue from a surgery. It could be related to muscle contracture. So you can still have a numb nipple, but pain around it for multiple reasons. We've seen that with several of our patients. Is it permanent? It just depends. For example, if you have numbness in your nipple after a breast augmentation, either the nerve was stretched or damaged during the original augmentation, and removing the implant might not change that. We've had a few patients who have had some return of sensitivity.
Mhm.
So it just depends on the scenario. If the nerve was damaged originally, then unlikely to get sensation again.
Okay, awesome. I've had tests done and nothing's showing on the tests.
Yeah,
MBII.
yeah. So that's good. You had the test done, so it shows you that okay, it's is it scar tissue in there that's causing it? If it's, is there a cyst or something that's causing that pain? So the test will kind of help exclude different diagnoses that can cause to your pain. But nerve type of related pain or issues you won't see on any specific test. Mostly it's a clinical diagnosis.
Awesome. We have a question from that was submitted yesterday. When explanting and lifting, how do you preserve the tissue? How did you re-augment with the tissue?
Yeah, so with the lift is designed to do a few things. It makes the areola that's enlarged smaller, and then it tightens up loose skin. And so, you know, we have different lift styles that we do based on how the loose skin and the breasts have settled. And so I don't take any breast tissue out unless a patient has a large volume of redundant breast tissue, then we do it for some contouring, but I don't take any of the breast tissue out. And then with the lift, we usually just kind of reinforce, readapt, flip, rotate the tissue depending on how much you have to fill in those areas that the implant used to live in. And so you kind of try to create more upper pole fullness, but I will tell you that, you know, the job of the implant is to fill the
Yeah,
space over here.
I
Your
tell
own,
that all the time. They were asking, "Are we going to be full up here?" And I'm like, "No, you're
yeah,
not. That's why you
yeah,
had an implant." Yeah.
exactly. And it might look full in the beginning because it's swollen, the muscle's
Mhm.
swollen, and but as time goes on, everything settles to a more natural look.
What about breast reduction with the explant? Because I know sometimes we have patients say, I want to be as small as possible because now there is more of a trend to be smaller as opposed to being larger years ago. What about that? How do you deal with the patients with breast reductions?
Yeah, you have to be a little careful doing breast reductions with the explants, just because of blood
Yeah.
supply to the nipple. So as you're removing tissue, you know, you remove the implant, the whole capsule, so you've created that trauma in the red. Then now you start removing breast tissue, you can actually end up cutting the blood supply to the nipple,
Mhm.
and then you'll end up getting nipple necrosis. So you have to be really mindful and careful
Right.
about doing full breast reductions. I usually try to remove breast tissue from the side portion of the breast. That's where there's bulky tissue, and depending on the blood flow to the breast, it'll allow me to decide how much I can remove and how much I can do. But in general, you know, you have to be really careful doing formal breast reductions.
Then, so what about on the opposite? What if a patient has very little tissue? What are the risks on that procedure?
Um, the risks aren't necessarily different from a regular explant and doing a lift. The issue becomes being able to reconstruct the breast. You know, when you don't have much tissue, you just don't have the opportunity to do any reconstruction or fill in those spaces. So we see a lot of deflation of the breast.
Mhm.
Sometimes you have a little bit of loose, redundant skin. You know, the cosmetics may not be too appealing to patients because they're used to having these kind of large implants in there that are filling in those spaces, and now they don't have the implants, and so that space is kind of void.
Mhm.
So those are some of the cosmetic concerns and expectations we have to create, and those can be absolutely challenging, and it's a valid concern of patients. So we have to create realistic expectations and sometimes guide our patients on what to expect afterwards.
Right, because then you have the patients, whether some patients do not want to lift, and if they have a lot of redundancy, then what happens then with
Yeah,
that?
so yeah, the redundant skin, I mean, we try and we decide about whether we should tighten the skin or not, or if scarring is an issue and patients don't want the scars and they want to see how the skin settles, we remove the implants and the capsule and let the skin settle over the course of a year. During that year, though, we do a lot of grooming, external molding, as we call it, which is unique to our practice. So we teach patients certain massage techniques, cupping, myofascial release to help soften the skin and allow it to shrink and contract. And then once we hit that 1 year mark, then we decide.
Yeah.
The skin tells us where it's going to be, and then we can offer things like small skin removal, small fat transfer, some things like that.
I'm excited about recently you've been removing the implant through the areola.
Yeah.
So it's almost a scarless removal. Can you talk to everybody about that? Because I'm really excited about that procedure.
Yeah, this has been great. Something I've been working on. Yeah, I've been working on this for a little while, and the concern with removing the implant and the capsule just through that periareolar, so it's a half moon incision. It's tiny. It's around the areola. Is one, visibility is not great through that incision, and two, you always have the risk of getting your nipple indenting in afterwards. So. So a good candidate, if someone who has a large areola and has a previous incision there, I think it's great to go through that same kind of incision without making additional scarring on the breast. So that makes somebody a good candidate. And then, once you have that access point, then it just doesn't matter how big the pocket is. You're able to get in. I'm able to repair the muscle if I have to. I can see the lymph nodes. Your visualization is pretty good. And then the reconstruction part, so patients have to have some decent breast tissue to reconstruct it. So that comes with my physical exam. So I'll kind of give them a gauge of, okay, here's your healthy tissue. I'm able to kind of scaffold it to prevent that nipple from indenting down inwards, and then.
But the
if they're at
areola
higher risk,
is not changing. The areola size.
no, I mean you can. If it's too large, then you can always extend your incision and do a complete circle. We call that a donut or a Benelli lift. And so we can do an areola reduction through that. And it's great. I mean, we've done it probably on 5 to 10 patients recently. The results have been really good. The ones that develop some puckering, we have different massage, pinching, cupping techniques to help soften it up. So
I'll start new highlights on that procedure.
Yeah. I mean, it's the least scarring of any type of explant.
I think it's ideal. I think it's great that you're starting to do this. Okay, someone asked about implant size and type. Does that make a difference? Does that affect the outcome of the explant and lift?
I think the size definitely does. If you have a 200cc implant versus an 800cc implant, the tissue stretch is quite different between those two. And so the reconstruction gets a little bit more challenging with larger implants because of the stretch of the implant, the damage is done to the surrounding tissue. So size-wise, I think the larger the size, the more tissue stretch you can anticipate, the larger the pocket. As far as implant types go, I think the textured implants tend to be more challenging just because of the amount of inflammation they cause on the inside of the tissue. And that inflammation leads to swelling in the breast, and then the reconstruction gets a little bit more challenging when there's a swollen breast. So, but whether it's silicone or saline, as far as intact implants go, those don't really affect the final outcome. Obviously, if there's a rupture, that changes things a little bit, but size, I think size and textured implants in general make the case a little bit more challenging.
Can you talk about the difference between intracapsular rupture and extracapsular rupture?
Yeah, so when we put the implant in, as we all know, the body forms this beautiful capsule around the implant. And so when the implant ruptures and it's contained within that capsule, so nothing's leaking out, that's called an intracapsular rupture. So when there's a violation, so say if the capsule tears or it breaks, then the silicone or saline will leak outside of it, and then now it becomes an extracapsular rupture, and all that silicone or saline has leaked into the breast tissue.
Is that considered dangerous? Is that a reason why a patient should be running to the operating room to remove the implants?
Yeah, I think, especially with most saline ruptures do rupture in extracapsular. When we go in, it's completely deflated. And so those patients with intra or extracapsular deflation of saline implants, they have pain, their tissue gets tight, swollen. If there's an infection, obviously that needs to be addressed immediately. With the silicone, yeah, that silicone, if it starts bubbling out into the tissue, it forms hard granulomas, calcified, thickened scar tissue. It can go into the lymph nodes. It can seed itself and form lymph node granulomas in the armpit region. So if there's an extracapsular rupture, I would say those should be taken care of more urgently than anything else.
Do you think a mammogram would worsen the scenario for a patient?
Yeah,
And with patients, we say don't have a mammogram until after the procedure, or go ahead and have a mammogram. What's the difference?
yeah, I mean, I think there's a lot of controversy on the utility of mammograms between different practitioners, but in general, if you're getting a mammogram, there's always that theoretical risk of compression and having an issue with the implant rupturing. We've had several patients. Yeah, we've had several patients comment on it. They're like, I went and had a mammogram and I felt a pop or a pinch. And,
yeah.
I think that's what's caused it. And you compare their last year's mammogram to the current mammogram, and you see a new rupture on the mammogram, which may not be the best imaging to detect a rupture, but that's what they think that has happened. So yeah, you have to be cautious with that. But also imaging is important because if someone say has a family history of breast cancer or lumps that need to be tracked, we don't want to go in and operate on somebody that has these pre-existing things that we want to make sure that are not, any type of cancer, make sure they're benign lesions. So then they're like, okay, well, what do I do? And then so if they don't want to do a mammogram, they consider getting an ultrasound, which is fine. Sometimes we recommend an MRI.
How effective
to actually
are the MRIs? Because I know we've had patients who've had MRIs and they come in and they actually do have ruptures though.
Yeah, I think it's the gold standard for detecting a rupture. It's maybe 95 to 98%, sensitive. So that leaves a 2 to 5% open window. So we might have captured some of those patients whose ruptures
I remember
don't really appear.
Yeah.
Yeah.
We were all shocked that she had, I think she even had a double rupture. One was like really almost liquid. It was so bad.
Yeah. So there's certain telltale signs on the MRI that detect the rupture, but is it 100%? No. And so we've captured some of those patients in that scenario.
Okay, let me maybe, it says, good morning. So excited about my explant surgery in November. We can't wait to see you.
Coming up.
Let's see. So truth, myth, or let's see, how far are you booked out for explanting? So
it's a good question. I mean, I've been people or patients come up to me and be like, "Oh my God, are you booked out a year?" And the answer is no. We book patients out throughout the year for sure, based on scheduling and needs and vacation and work.
We always have openings. If someone always getting sick, their clearance didn't go through, they have to reschedule for whatever reason. We trade dates with patients. So I may call you, somebody, a patient that's out there, may call you one day and say, hey, do you want to trade with someone? They want to go later. Do you want to go early? It just works out. There's always a way to work things out.
I think the cool thing about our practice in Miami is we've kept slots open. And we've done this from patient feedback because for urgent cases, ruptures, severe pain, severe symptoms, breast implant illness related symptoms. So we keep spots open. Local patients want to get in. People who travel, and they're very specific about what they can do. So I think, if you need to get in the next 2 weeks, sure. I'm sure we can work it out on the schedule. I don't think that's an issue, but that's where your expertise comes in.
It always works out. We have patients that their flights get canceled. All sorts of things can happen, which opens up like very soon, very near future opening. So we can get patients in, and that's really important. I tell patients all the time, just tell me, ask me, when do you want to have your procedure, and I'll see what I can do to make that happen.
Yeah, the other thing is with the consults too. Patients are like, oh, we don't want to wait 3 or 4 months to consult with you, which is where you've done a great job opening up consult days to talk to you, to get that initial conversation going. And then obviously I've opened up virtual consult days and more in-person days so we can get those consults.
Yeah, I think that's
which I think is important. Nobody wants to wait 3 or 4 months.
No. And some just cannot. Definitely, we don't have the luxury of that. So let's see. I've had my breast implants out a few years, but didn't do a lift. My right breast is not drooping. Don't want. Can you see these, Dr. Dev?
Um, Let me see. Which one are you on?
I've had my breast implants taken out a few years ago, but didn't do a lift. My right breast is not full and drooping. Don't want any more surgeries. Can anything else be done to give me fullness?
Yeah, I mean, it just
So
depends on,
non-surgical basically is what she's asking.
yeah, non-surgical. I mean, the only thing that I have had my patients do to try and help tighten the breast and volumize and create a little bit more tightness is we encourage doing a lot of upper body chest exercises to help build that muscle. And the underlying muscle, as it grows and it increases in volume, it might add a little bit of volume, but it also might help tighten the skin a little bit. And then we've been using a lot of our patients have been using castor oil as a nice trick to apply on the skin to help with skin tightening as well. So we've seen that work pretty well. So those are some of the non-surgical options. But if you're looking at modalities, non-surgical modalities, there's things like Morpheus and radio frequency and lasers that can help tighten the skin a little bit. So you can kind of look into those options. Again, those are procedures, but non-surgical. They end up being costly. You end up needing 3 to 4 sessions.
And it's so little difference. That's what.
Yeah, I mean, you can if 10 to 15% improvement is worth it
And it's
in a patient's
expensive.
opinion,
Cheap.
yeah, then it's okay to look into. But it just Diane 7895. It just depends on the amount of drooping you have. I think yeah, more of a physical exam will help determine if even non-surgical options are good for you.
Great, thank you. Where do you get the fat from when you're doing fat transfer?
I, I love going to the abdomen, the flanks, upper back, and the thighs for my fat pockets. I will do maybe some arm contouring, but you don't get a lot of fat from the
Right.
arms.
Yeah.
The quality is not the best. I always lipo the armpit area when I do fat transfer just for some contouring there, but I think the best quality fat is from the abdomen, flanks, upper back, and thighs. I don't like to go in the back of the thighs. That kind of transition between the buttocks and the
Oh,
posterior or the back thigh. I know a lot of people try to do that. I think it's a bad idea. I think you're disrupting that continuity between the bottom and the legs, and it just creates this kind of weird continuity and
mhm.
dimpling. So I don't go on the back of the thighs. I might do a little feathering there if there are fat pockets, but I won't do any like aggressive liposuction there.
For Nikki, do you see Nikki? For those who are for positive, is there anything different?
Mhm. Yeah, we actually, our whole protocol is designed to presume everyone is MTHFR positive because I just think it's not widely tested. I don't think too many people know about it. The patients who do know about it usually are in the hunt for some source of yeah, medical issue that's causing them to feel systemically ill. So most people, I think, don't know about it. So we've designed our entire anesthesia post-op medication protocol around that. So we presume, so we don't use any type of anesthetic that will affect an MTHFR positive patient. The only thing we don't that we alter with confirmed MTHFR is we don't use the folic acid as a supplement in one of our IV therapies. But other than that, our whole protocol is guidelined for that presumption.
Okay. I have my implants since 2004, suffering from a lot of symptoms. I want to remove them. What is the first step to start the process? I think you just took it. Just give us a call. You can send me a message and I will call you and we can arrange a consultation, a phone call. If you're local, you can come in and see Dr. Dev. If you're not, we can do either you and I can have a phone call or we can arrange for Dr. Dev to call you. Let's see, is there any way to do fat transfer to remain full after explant? I think we kind of covered that a little bit. Do you want to chime in on that one? Is there any way to do a fat transfer to remain full
Yeah,
after the?
I usually like to wait a full year for the breast to settle, and you'll there's a lot of docs that do it at the same time. I used to be one of those. I used to do some fat transfers. My reasons for not doing it is one, the tissue is super swollen after the explant and the lift, and fat you can inject fat into that swollen tissue, but fat needs a really good home to survive in. So it won't really survive in that swollen tissue. It'll look amazing in the beginning.
Yeah.
On table, you're like, oh my God. And like 3 or 4 weeks later, you're like, wow. And then as time goes on, it just
Yeah, it
vanishes.
can be really disappointing. I think
Yeah.
9 out of 10 patients that inquire about it never move forward with it. They're just happy.
Yeah. So, I like to wait, and then you see where your breast settles, the scar tissue softens up, and then, like you said, 9 out of 10 are happy, and then that 1%, they want a little bit more fullness, they want to correct some contour irregularities, and we consider fat transfer down the road. But just remember, fat does not mimic an implant, so you're not going to get a lot of upper pole fullness. Everyone's like, I want to fill. It might help soften that transition zone between the upper chest and the breast, that kind of dip. I think it can help soften that a little bit, but it's not going to fill it in where you feel like you have that rigid fullness. Fat is soft, and implants are more rigid
Over
structures.
this with patients all the time.
Yeah.
What is best imaging to detect a rupture?
Ideally, gold standard is MRI. If you want to start with the simple, basic one, you can get an ultrasound just to see. But if you want a definitive answer, I think MRI is the gold standard.
How long after explant lift can you start working out?
So initially, the one thing I want to say is never do T-Rex after the explant.
I don't know who started the T-Rex, but it's just.
I mean, some docs advocate it. You might need it if you have a full-on muscle repair where then you might need T-Rex. But in a general setting, your arm movements kind of stay in this bubble region, and then you can start doing abdomen and legs at 4 weeks, and then upper body at 6 weeks. Yep, wash your hair, brush your teeth, sanitation, that's okay.
That's all okay.
But working out like 4 weeks is the time frame, and the reason for that is if you start working out earlier in the process, your heart rate, blood pressure go up. You're going to cause a lot of swelling in the breast, and then if you do too much aggressive movements, you can cause shearing, fluid buildup, the infamous seroma. You can tear your muscle, you can cause your incisions to break open. So those are some of the reasons to chill for 4 weeks.
Can you explain a little bit, now you're talking about the seroma, what exactly is a seroma, why we use the drains to avoid them?
Yeah, so the seroma is a collection of fluid, post-surgical fluid, in the pocket where the implant used to live. And when we do these surgeries, I do a lot of irrigation. There's a lot of, raw surface. It's a big, big cavity in there, and we rely on it to collapse and back into its normal anatomical location. So I put drains in to prevent fluid from building up in there. And if that fluid builds up and sits in there and your body can't reabsorb it, it's prone to infection, or you can get like this big water bubble in there. So I like to use drains just to help everything drain out, and we leave them in for 5 to 7 days. That doesn't mean you're at risk of developing seroma later too. If you take the drains out and like a week later you're vacuuming, repetitive movement, blow drying your hair, everything's causing friction on the inside, you'll get fluid buildup. It's the type of fluid buildup that exceeds what your body can absorb, and then you'll come in and be like, oh, I feel like I have a water balloon in my breast, and we'll end up draining a seroma, or we'll get an ultrasound to confirm or deny if there is a seroma.
So what's the remedy to seroma? What do we do?
First is do nothing. You can wait and see if it goes down. If it doesn't, if it's painful, if it's really big, it's obvious, you can see 2 different sizes, then we do a bedside drainage. So you have to come in, we have a needle, we have to insert it into that fluid and then drain it out. Sometimes you have to do that 2 or 3 times to completely resolve it. If it doesn't resolve with that, then you have to go back into the surgery to remove the seroma capsule. Similar to how breast implants form a capsule, seromas can form capsules. And you have to get rid of that capsule and that fluid and kind of start from square one.
Exactly. Again. This is why we wait, and I tell patients this all the time. We need to wait a little bit. We have patients calling, and please remove them, and they're like trying to con us into talking us into removing them early, and it's just not a good idea.
Not worth it. Yeah, just forget that serum. But I want to also, with the drains, there's a myth that drains prevent hematomas, and that's not true.
Okay, that's a good
But
one.
yeah, the hematoma is going to happen with or without a drain. It's mostly if one of the blood vessels open up, whether it's an artery or a vein, some trauma in the area. And so you're going to bleed into that breast pocket, and the drain's not going to prevent that. The drain will cue you to, so the drain will start collecting the blood, and patients will be like, oh my God, my one bulb is really bloody compared to the other that looks like Kool-Aid. And they're like, okay, send me a picture. And one breast looks like it has an implant in it again. And so,
Mhm.
and then they'll be like, oh, it stopped, the drain stopped working, and it stops working because it's clotted with blood, but everything's still filled in there. So the drains do not prevent hematomas. They'll help you identify it, but that's one myth I wanted to correct.
Good, that's a good one. And then, so what if they do have a hematoma?
Mm-hmm. Yeah, so the hematomas in the breast, it's a confined space. So when you bleed into it, it bleeds a certain amount. So it's not the type of bleeding you typically have to run to the emergency room for, because it'll expand to how much ever the pocket is, and then the blood vessels will just kind of get compressed and they'll stop bleeding. But patients will feel pressure, pain, obviously. Some of them get a little bit dizzy from the bleeding. So we like to address it pretty soon, especially when it's a hematoma that's filled up the entire pocket. And
Okay.
so
And
usually they'll call, yeah,
mhm.
so that's the type of stuff that'll take you back into surgery. And so we will have you come in, we'll get you hydrated, and then we'll take you back to surgery and open up the pocket and clean all that blood that's collected in there, try to find the offending source, and then put fresh drains in and then start from scratch.
Mhm. Okay, thank you. How does a ruptured silicone implant affect your body? How do you deal with psychological changes, especially when your spouse questions what your breast will look like? He's a boob
Yeah,
man.
that's a tough one. I mean, when you're considering explanting, one, we look at the reasons for explanting. And then two, we look at support. So, you have to have a good support system, meaning you, your spouse, significant other, husband, you guys need to be on the same page for it. Because once you remove them, there's going to be a change in obviously the breast shape, the form, and the size. And so I think the best way to talk to a significant other about it is, one, to explain why you want to remove them, and then you dive into things like before and after pictures to show
And you'd be
what things look
surprised.
like.
It's there's so many guys out there. I mean, few and far in between that are totally against the procedure, and they actually adapt to it and just happy to have their wives back to
Yeah,
who they used to be in many
yeah,
cases, and it's really not as bad as many women think.
yeah, yeah. And I think, I mean, even say if a husband is not like involved in that process, even for our patients, it's a little bit of an anxiety ridden process to envision what your breasts are going to look like. It's very challenging to consider that. And then you go online and you see pictures, and some pictures you may not like, some pictures you may love, and you just kind of like start kind of getting into this hole of like, what am I going to look like? And it's nice to compare apples to apples and try and find someone that matches your frame, your breast size, your implant size, to compare what you could potentially look like afterwards. So I think having that discussion, looking at pictures with your husband, spouse, significant other, just to kind of get an idea of what the natural breast looks like, what the scars look like, how they progress over years. Just getting them involved is a useful process in kind of alleviating some of those anxieties.
Or as we did in my little skit, we can always trade in the husband. Just kidding.
That's funny. No trade-ins.
Let's see. Because of your videos, the women experience have given me hope that I can feel better. That's great.
Thank you.
That's the whole purpose. We love the honesty. Thank you. And surgery, Dr. Dev. Should I refrain from alcohol for a certain amount of days before surgery? Hoping no.
Yeah,
Hmm.
in general, alcohol sometimes increases the bleeding and swelling and bruising afterwards. It dilutes the blood, to put it in a simple way. So we prefer you don't drink for about a week before the surgery. Um, if you're going 8 to 12 days, I would say enjoy a little bit in Napa. Don't overindulge. But then definitely a week after, I would refrain from using any alcohol. And then you can take things like arnica to help with bruising. You can start the arnica a week before the surgery and continue it for a week or two afterwards to help prevent the bruising.
What about smoking and vaping? Can we talk about that? Because
Oh man, yeah,
it's a big one.
the bane of smoking and vaping are horrible. All of our forums we talk about smoking. I think vaping has become a big concern because I think
It's
a lot of people
huge.
think,
It's huge. And I think patients downplay it, or they just really don't. Maybe they're not aware of it. That they.
yeah,
Mhm.
yeah, no, there's a lot of these vapes contain nicotine, and the load of nicotine is often more than cigarettes too. And you're puffing and you're pulling on these, so not only do you have nicotine in your system, it affects the kind of the physiology of the lungs too. But the big thing is, with smoking, vaping, gums, any form of nicotine, eye drops, whatever they come in nowadays, you don't want nicotine in your system because that nicotine, when your blood vessels are like these huge pipes, when you take nicotine, they constrict and they become like these tiny little straws, and the healing tissue just doesn't see the oxygen and the nutrients and the blood it needs to heal and survive. And so you automatically double your risk of like infections, wound healing issues, nipple necrosis. It can get really messy. So especially when you're doing lifts, the lift and the reductions are the
Yeah,
big
and we've
big
had
things.
we've had patients that test positive, and because you will get tested the day of, and then you just explanted and not move forward with the lift.
Yeah, I will not do a lift if you're tested positive. So I'm happy to remove the implants and the
Mhm.
capsules, but definitely tissue manipulation is a big no-no. It's too
Yeah.
dangerous. So,
So your surgery will be canceled, or you'll only do half the procedure.
yeah, or we postpone it. If we have to, we'll say okay. We did it recently.
Hmm.
We postponed the surgery by 4 to 6 weeks. We
Yes.
track the nicotine levels. We assist you with learning how to flush things out of your system with hydration and exercise, and you'll test negative. But we do recommend at that point doing hyperbaric oxygen therapy
Mhm.
to allow and help with wound healing to maximize oxygen to the healing tissue. So that's one thing we add for those who have tested positive in the past, because your blood vessels are still going to be affected.
But this also applies to breast lift only, correct?
To things like, yeah, breast lifts,
So we're doing a lot
breast
of breast
reductions.
lift only now too.
Yeah,
Many
yeah.
patients ask that. Do you perform breast
Mhm.
lift only?
Yeah,
Absolutely.
yeah, yeah. Most of our explants get a lift, so just doing a
Mhm.
breast lift itself, it's a great option to lift your breasts up. Um, I think the other, with back to smoking, we don't do them with tummy tucks too, so that's another
Right.
no.
Well, so tuberous breasts before implants. When you explant, would they go back to tuberous?
Yeah, no, that's a great question. If the tuberosity has been corrected from the implant surgery, so when tuberous breast, everything looks like a cone. When you put the implants in, the goal is to create like a hammock so that that cone effect is gone. So if that's corrected from the implants, then you won't have much tuberosity. If your breasts are still tuberous despite having implants in there, then yeah, you might end up with some residual tuberosity. But most of the time, the reason the implants were put in were to help correct that tuberosity, and it won't persist after explantation.
Can you correct it if it didn't self-correct it? Can you correct it with a
Mhm.
lift?
You can improve it with the lift, and then you might need a secondary procedure to help correct some of the constriction. So I usually, I'll release the constriction bands and allow the breast to kind of round out, and then sometimes you have to do a fat transfer as a second stage procedure to fill in that area.
Okay, that makes sense. I'm using GLP-1 medication. My surgery is in November. When should I stop injecting?
Yeah, our hard stop is 2 weeks before surgery. There's some studies that are suggesting 4 weeks before, but most of those studies are done for intra-abdominal surgery. So for our situation, we usually say 2 weeks before is a good timeline to stop it. And the other thing is to resume it. You want to wait for 4 to 6 weeks after the surgery to start taking it again, because we want you to maximize your nutrition and your oral intake after the surgery. We don't want you to be malnourished and not eating enough.
Immediate post-op, I know one of the questions was, and it's been brought up, do we give pain medication immediate post-op, or are they waking up in excruciating pain? That's their fear.
Yeah, no, we have all types of pain medication. So one during the surgery, I do the if a patient opts to get it done, which I 100% recommend doing the nerve block.
Mm-hmm.
So we mix that nerve block with some other medication so that it starts, you have a bridge between surgery and when the
Uh-huh.
nerve block kicks in. And then our anesthesia team provides pain medication during the surgery. So we give Tylenol before.
Mm-hmm.
We give IV pain medication during the surgery. I do the nerve block, and then if you're still struggling in recovery, then yeah, we have either IV, intramuscular, or even the oral pain medications to help you afterwards. So the one thing we really try to avoid is using any narcotics. So we don't use any fentanyl, morphine, dilaudid during the surgery. That's the stuff that really makes you nauseous and icky. So we have other medications that we use. But yeah, absolutely. I mean, we want you to go home feeling comfortable.
Right.
So
Mm-hmm.
we will never deny anyone
Yeah.
pain control.
Okay. Someone is asking about, is the capsule and an explant breast or buttock? Does the capsule have to be removed?
Yeah, no, it's a great question. Something that we're always discussing amongst our peers, colleagues in our societies. There's controversy on whether taking the whole capsule out is necessary or not.
Mm-hmm.
When you have ruptures, capsular contracture, calcifications, those are, indications definitely for a total capsulectomy. When it comes to systemic symptoms and breast implant illness, that's where I think there's some controversy. From my own principles and beliefs, I like to do a total capsulectomy. I and the reasons being, these capsules, if say if you just take the implant out, the capsules, they don't dissolve; they're always in there. A lot of time they contract and shrink, and patients complain of pain and difficulty moving their arms, this rubber band effect. So we've treated patients who have had residual capsule, and we've removed them and alleviated them from some of those symptoms. Some patients have reported improvement in symptoms of breast implant illness after I did a secondary capsulectomy. So I think it's a safe procedure. The complication rates are not high; they're very comparable to all the other procedures we do. And we do quite a few of them, so the technique I think is quite refined. I think it's easy enough to do that procedure. So while I'm in there, I prefer my surgical technique or preference is to remove the whole capsule, wash the entire breast pocket. If we need to repair the muscle, I'll repair the muscle, and then just assess the integrity of the lymph nodes and nerves, and just kind of do a surveillance to see if anything else is going on.
What would uh, what occurrence? What would happen that would make someone have to have muscle repair? What could have happened? Could it have been prior surgery, or just
Yeah,
the, their
yeah,
lifter, or
yeah. No, we've seen, we've done a lot of muscle repairs for not only patients who have had explants for cosmetic reasons, but mastectomy patients whose muscles have been completely detached. So my criteria, if the muscle has been torn, cut during the original surgery in a way that it's gonna really cause functional deficiencies, then I'll consider doing. I'll assess the integrity of the muscle and do a formal muscle repair. Um, you know, we we do see some situations where the muscle is contracted and hiked up, and some are you don't want. You can do more damage than harm by trying to pull that muscle down and repair it. So, some of them, if they look anatomically correct, you let them settle in place and they fall back into place and you get full functionality. So typically, if someone's muscle has been completely disinserted off the bottom of the rib cage, and as long as it's not scarred and contracted up here and it's mobile and movable, then I'll do a full muscle repair. If it's been split or cut to put the implant in, I'll do a muscle repair. But I don't think everyone needs a
right?
muscle repair necessarily. Yeah.
Does it affect the pain level? I know patients have asked.
I think the recovery is a little bit.
Over the muscle, or underneath the muscle? Does it make a difference in the comfort level?
Yeah, yeah, I mean, under the muscle, I think is more painful than over the muscle. Over the muscle, patients complain of more burning because the breast tissue gets a little bit irritated and they feel like there's burning in the breast, but I'll inject that numbing medicine all throughout the breast. Underneath the muscle is you do some muscle manipulation, and so that's a little bit more sore and painful than over the muscle, for sure.
Patients have asked the anti-nausea medicine that we have the patients take, the aprepitant.
Yeah.
On some occasions, their insurance doesn't cover it and it's expensive. So they ask, do I really need to take this?
Yeah.
Do you want to talk about that a little bit? Why?
Yeah. I think if you have a history of severe postoperative nausea and vomiting, so you've had other surgeries and you've woken up feeling absolutely horrible, you're throwing up, you're like, oh my God, this is miserable, I never want to have surgery again. I think it's worth paying the 90 to 100 bucks for this medication because it will really help alleviate that issue post-op. And plus, we don't use any narcotics, so those things really help. So, if you don't have a history of post-op nausea, vomiting, you're like, yeah, I've woken up fine, I've been, and your insurance doesn't cover it, then we don't really push for you to get it. So,
So
just
is a
look at your
patient
history.
that's heaving and throwing up, and are they more likely to have a hematoma?
Yeah, no, when you're heaving and throwing up, I mean, hematoma risk goes up, so the breast gets super swollen. I mean, it prolongs your recovery. I think it makes it a little bit more challenging.
I had this
Yeah,
discussion with the patient recently that it's really worth it because of the risks of
preventing
not having a
that.
hematoma.
Yeah.
Much less likely. Exparel, how safe is it?
Very safe.
What exactly is it? How does it work? Is it injected? Is it?
Yeah.
They're asking if it's a pump. What exactly is Exparel?
Yeah, so Exparel, it's a special medication, a numbing medication that is placed in this extended release kind of bubble. And it's an injection. So I injected during the surgery. I bathe the nerves that supply the breast and the chest wall with this particular medication. And it usually kicks in like 4 to 6 hours after the surgery. And it usually lasts for about 3 days. So you will still feel like you had surgery. And most of our patients,
pressure, and most of the patients just take Tylenol, maybe, but it really avoids having to take the narcotics. I remember I used it. I thought it was amazing. So
yeah, I mean, we use it in everything. We use it for tummy tucks. We use it. I mean, they use it in other specialties. My dad had it placed for his knee replacement, and he was cruising for the first 3 days. So it's a great medication. If you pick anything of all the additives that we give, I would say Exparel should be the top of your list because pain control is super important. Narcotics make you feel horrible.
The process a lot more pleasant, that's for sure.
Yeah.
What kind of, this may be a silly question, what kind of type of filler used in a fuller breast?
Yeah, I would caution against using any fillers in the breast. The only filler that I use is your own natural fat to fill in the breast, but yeah, be careful about being offered different type of. There's so many fillers out there to be placed in the breast. You're just asking for trouble.
Yeah, that's a big surface to cover too. Let's see. Exparel is $350 additional.
Yeah, it's a pricey medication.
Yeah.
So, and that's the only reason we have to charge for it.
Yeah, although it's still September, so just want to remind everyone, I did run a little special for my birthday, and so up until September 30th, you get free Exparel if you schedule a procedure, and complete your procedure by the end of the year. I'm not allowed to after the end of the year. I can't give any more. So
it's a great promo. Wow.
I know. I was really happy about it. I kind of threw it out there and it stuck, and so it's still there. So September 30th, you still have 6 more days. Okay, so didn't feel any pain after surgery. That's awesome. Love the Exparel. Se puede hacer mamografía. Sí, se puede hacer mamografía 6 meses después de la cirugía. You have to get you talking Spanish, Dr. Dev.
I do.
You understand more than you speak.
I know.
Tummy tucks. Let's talk about tummy tucks because we're doing a lot of those as well. Um,
Yes.
muscle. Does everyone need muscle tightening? There's extended tummy tucks. There's mini tummy tucks, and then there's a regular tummy tucks.
So mini, well, I love doing tummy tucks. I think it's a super cool procedure.
Yeah.
Um, the benefits are amazing. The mini tummy tuck is just removing skin on the bottom. So a lot of patients will be like, "Can you just do a mini?" Because they don't want the scarring. It just depends on how much loose
Is
skin you
there
have.
any muscle tightening during the mini?
You can tighten the lower portion of the muscle below the belly button. I just don't think that's a great idea because you tighten your lower abdomen, then your upper abdomen is loose. It just
Yeah,
looks weird.
it
So
looks strange. Not,
for
yeah, very few people are good candidates for it.
Yeah, yeah. So with tummy tucks, the goal is to remove all the excess skin and then tighten up the loose muscle. Most patients who have had children or have had weight loss situations, their muscles are spread. A lot of patients genetically or through their own efforts have been able to reduce the size of their muscle spread or diastasis. Um, some patients in those situations don't really need a muscle repair, but in general, most patients need a muscle repair to reconstruct that muscle. It's from the top over here all the way to the bottom,
Mhm.
and that helps with contouring. And then we remove all the extra loose skin, tighten everything up, contour everything nicely, do liposuction to really accentuate all the
What
kind of
about the reverse
shadows.
tummy tuck? So many patients have asked about reverse tummy tuck
Yeah.
during an explant or lift. Can we talk about that?
Yeah, I've done several of those. You have to be okay with the scarring from that. So the scar will literally go from the middle of the chest area all the way to the side in order
Mhm.
to fully get the benefit of a reverse tummy tuck. So reverse tummy tuck, you're pulling up skin from the bottom up.
Can it
Um, you know,
drag down over
it
time?
you can get a little bit of drag for sure.
Hmm.
And if you're like, oh, I want, if you have a lot of loose skin right above your belly button and you pull it up and you're like, this is what I want, I don't think a reverse tummy tuck can do that. Theoretically, you can do it with your hands manually, but surgically to achieve that, it's very challenging. So, if your upper abdomen skin is a little loose and you're like, I feel like, when I lean forward, I have a little loose skin, then it's fine to do reverse tummy tuck. You just have to be okay with the scarring. But if you have loose skin around your right above your belly button, it's not going to change with the reverse tummy
Does
tuck.
it make
I don't think.
a difference if you're lifting also? I mean, is it not a good idea because you just had a lift?
Um, the blood supply we're preserving comes from above, so sometimes it's okay to do it.
Mhm.
I think it's a case by case decision.
Oh, liposuction of the upper abdomen during a tummy tuck.
Yeah, yeah. So it's selective. You can do it. You have to be really careful.
Hmm.
When you're doing the tummy tuck, you're making an incision on the bottom, so blood supply from the bottom gets cut off. You rely on blood supply from the top and the sides to support the healing tissue. So you have to be really careful how much you do centrally. So you can do like some deeper liposuction. You can do maybe sometimes a little bit of etching, so that's isolated. But if
Hmm.
you have big pockets of fat on your central abdomen, you can debulk it a little bit, but when you pull it down, you have to make sure you have enough to support the healing tissue. So some patients complain of a little bit of a bulge or bulk there. And we talk about those usually before the surgery, so they're aware of that. And then sometimes, probably like 6 months to a year later, we'll talk about maybe doing a little touch up lipo in that area once everything has safely healed up.
How much liposuction can you do as a stand-alone as
Yeah.
opposed to with the tummy tuck?
By Florida law, you can only do with without any other procedure, just liposuction alone, you can do 4 liters
Hmm.
of lipoaspirate, and with other procedures, you can only do 1 liter. So that's based off of Florida law. So
Hmm. Is it safe to have 360 liposuction with breast reduction and
you
lift?
can, but you're limited by the amount you can take out. So
Hmm.
you can definitely do liposuction, but you're only allowed to remove 1 liter.
All right. So in these cases, sometimes if it's a larger case, they're better off separating,
Staging them, yeah.
waiting, yeah, staging them. Hmm. Okay. Um, and then as far as the mommy makeover, so we can do tummy tuck, liposuction, breast lift. Explant
Breast
lift.
lift. Yep. Yeah. Called the reverse mommy makeover, natural mommy makeover.
Mhm.
So we don't use any implants, obviously. We're removing the implants. We're reconstructing the breast. We're doing tummy tuck. We'll do liposuction. We'll do the 1 liter that we can. And then oftentimes, if it's just a breast lift, so not an explant, but just a breast lift, then I'll do a fat transfer to the breasts.
And the
And so
tummy.
we'll do a, yeah, yeah. And we're not injecting large volumes. We're just trying to put a little bit on the top to create a little bit more fullness in that transition zone.
Mhm.
So it's not a large volume fat transfer. So, but we do all those together.
How is the fat prepared prior to injecting?
So we collect it in a sterile system, and
Mhm.
then we like to let everything just kind of sit there so there's a separation between the fat and the fluid that's used to collect the fat. And then
Mhm.
we drain out that liquid, and then so now we're left with this beautiful liquid gold. And then we we don't we don't centrifuge it or
Mhm.
anything. We don't process it like that. But then we do add some antibiotics to the fat, so it helps prevent infections when it's injected. And then then we collect it in our syringes, and then we do like these slow injections. So we do
Mhm.
like little lakes of fat, small dot in different layers, and we kind of cross them over, so we create a scaffolding of fat. It's pretty cool.
It is very, very cool. And I know patients have asked, how long is this? Is the fat transfer a forever thing, or does it? How much
Yeah,
is absorbed?
you're gonna you're gonna lose some depending on the situation. I mean, in an ideal situation, you'll see like 70 to 75% of the fat survive. Some factors reduce that percentage. Like if you've had a history of previous liposuction, your fat quality is not the greatest. If the
Mhm.
you know if you have a lot of scarring in your breast from previous surgery, the fat won't survive. So there's some variables that details we discussed during our consultation, but whatever survives, it forms a blood supply to it. So it has a nice robust blood supply, and
Mhm.
so it behaves like fat after that point. So if you gain weight, your breasts will grow up. If you lose weight, you're gonna shrink. So those are, but whatever stays, it stays.
How does it work when patients think that they should gain weight before their procedure, before their fat transfer?
Yeah, I'm not a big fan of that. A few pounds here, there is fine, but some patients like, oh, I'll put on 10 pounds and we'll do the fat transfer and then I'll lose it. Well, you're gonna do the liposuction, you're gonna inject the fat, and guess what's gonna happen when you try and lose weight afterwards? You're gonna burn all the fat that we injected.
Yeah.
So that's not the best idea. Um, I like to do it at your ideal or happy body weight. So if you're like, oh, I like to live at 125, 140, whatever the number is, then
Mhm.
stay at that number, because the minute you try and lose weight afterwards, you're going to burn all the fat.
Is it painful procedure?
The actual injection to the breast isn't painful. You might be a little sore. The liposuction can get a little sore. So patients compare it to like doing 200 kind of abdominal exercises or lower back exercise, you get that kind of muscle soreness. And so, but I think it's controlled well with Tylenol and muscle relaxers as well. And then once you start doing the lymphatics, that also helps mitigate some of the pain.
Why lymphatic drainage massage after?
So that, yeah, you don't, you want to prevent swelling and pooling of tissue or lymphatics in the tissue. So it helps smoothen everything out and helps prevent contour irregularities, indentations. It helps the skin to shrink and contract. So you want those lymphatics to clear out. You don't want to let swollen tissue to pool there. Otherwise, you're going to get these kind of weird lumpy, bumpy things. So lymphatics is super important um, after liposuction. I like to start it a week after the surgery.
Mhm.
A lot of patients ask, why do I wait for a week? We know a lot of people do it the day after. And my reason is when I do the liposuction, if I put in like 2 liters of fluid to collect the fat, I collect out 2 liters. So it's an even balance. Some docs will put in like 8 liters of fluid, but they'll take out 2 liters. So you have 6 liters of residual fluid. So they'll put drains in and they'll have you start draining. You'll see these videos of like people massaging the skin and then everything flowing out to the
Yeah.
incision. That's a little messy for my taste. I think you can get a great result with the even volume injection and
That can
removal.
be really painful immediately after
Yeah.
surgery. I don't know.
Yeah.
What about what exactly? Can you tell patients what tumescent fluid is?
Tumescent is basically, it's like saline solution that has lidocaine in it, so that's the numbing medicine, and
Mhm.
epinephrine, which helps constrict the blood vessels, so it prevents bleeding during the liposuction. So you have pain control, bleeding, and then the saline bathes the tissue, so it makes it easy to evenly remove the fat, preventing burns and stuff like that. So
And then the compression afterwards for 4 to 6 weeks,
yeah,
2 months times. Why?
yeah, you're as you're moving and as you start doing things, you'll get swelling in areas. So we want the compression so that you don't get swollen in those areas. The
Mhm.
swelling will just kind of create contour irregularities, and it will totally negate the reason for doing lymphatic massaging. So compression is super important to help keep things tight, help allow the skin to shrink and contract, and keep things in place.
On the breast, some patients we have more compression. What's the difference between each patient?
Yeah,
Right.
it's a very individual. Yeah, it just depends, how much tissue they have. You know, we don't if the nipple with the breast lift looks like it's needs that kind of blood supply, we don't want to compress it, so we
Right, they're
make those
struggling a
decisions.
little bit. Yeah, I tell
Yeah,
patients, yeah, it's just wait until after the procedure. So many patients want to purchase everything and be prepared, and it's like you need to wait because we don't know.
yeah.
Um, mhm,
Now you and the nurses have done a great job in creating like all these links, and
mhm.
so we see it, we decide what type of bra, band, blah blah blah, and we send them the links, and so everything's easily
Yeah,
accessible. So there's that anxiety
everything's
of what
easy.
not having
Mhm.
stuff is eliminated.
Let's see. Do we have to remove acrylic nails and gel nail polish before surgery? And she wants to know if she can dye her hair before.
You
Is that what?
can dye your hair. That's not an issue. Darker nails. We need one nail that's going to be able to pick up the oxygen signal for the surgery. So um, anything that's dark, we typically have you. I think like clear gel should be okay. It's
Mhm.
not a big issue. But any dark type of nail polish will skew the reading on the oxygen meter.
Okay. Okay. So let's see. So we're gonna take some questions now. Let's see. I think I covered everything I had. Um, I think we have patients. How do I know if I need a lift? Um, is there a difference between partial and full capsulectomy?
Yeah, yeah. With partial capsulectomy, you're leaving part of the capsule behind, and
Mhm,
full capsulectomy, you're taking the full one.
mhm.
Um, I think the terms we're using now are total intact capsulectomy. So the whole implant and the capsule come out in one piece together versus total capsulectomy, where sometimes you need to remove the implant or the to visualize and take the whole capsule out. But either way, in both scenarios, the whole capsule comes out. So nice clean pocket.
Can I do short-term water fast after surgery?
Um, we try to avoid doing any type of water fasting after surgery. We want you to stay hydrated. So my general rule of thumb is no fasting, no detoxing. Get your nutrients, drink plenty of liquids. Because when you have surgery, like all the fluid third spaces, meaning it's not in your blood vessels. So that's why patients' legs and arms get swollen. They feel puffy sometimes. So for the first initial phase, I just say stay hydrated, stay nourished. So eat plenty of healthy foods, proteins, and no detoxing initially.
Why detox after surgery at all?
Yeah, I think it's too harsh on the body. You're trying to take these people who do liver cleanses and enemas and juices, and it's just your body needs all that hydration and fluid. So give it. I always say surgery is like running a marathon you haven't trained for, and so your body goes through a lot of physiologic changes, and you don't want to insult it anymore after the surgery. So just give it a chance to heal up, and when you're ready, you can do detoxing and stuff like that afterwards.
But patients do not have to detox afterwards.
No, you don't. You do not have to.
Yeah.
Most patients, your body automatically will take over and heal itself. And yeah, some patients need support afterwards. They're still struggling or suffering. Then we'll kind of stratify some of their complaints and see if they'll benefit from additional support. But most of the time, you don't need anything.
Okay, perfect. Uh, sorry, I just got a call. Okay. Any other questions? Do you have anything you want to say on your own, Dr. Dev?
Yeah, I think with the explants, we've come a long way in identifying reasons to remove the implants. I'm glad that it's patients know now that it's an option to remove the implants as opposed to exchanging it. Even those who aren't sick from the implants. So I think it's been really valuable educating patients on what implants can do. You don't necessarily have to exchange them and go through surgeries multiple times. So that's been a big interesting thing in our practice. Patients just want to take them out because they're tired of having them. They're too heavy. They're just, it doesn't match their lifestyle or fit their previous image that they had of themselves with the need to have implants. So I think that's been really encouraging to see patients wanting to go back to their natural self and accepting their own natural form. So
I think there's a
that's been
big trend
exciting.
for that, and thank God for it. I think women just are just doing much better, thriving, smarter
Yeah.
now.
Yeah. Before, you always hear, oh, we didn't know removing them was an option, and now they're like, yeah. So now they're weighing their options, and patients are more educated. So that's been really encouraging to see.
Mhm.
And then, yeah, the natural mommy makeover has been really a great option for patients for contouring post-pregnancy or weight loss procedures to help recontour patients' bodies without the use of implants, and patients really love that option. So we've been fortunate to have patients from all over the world come see us for that, and it's been
As a
exciting.
plastic surgeon, how does that make you feel? I don't know that you ever imagined that this is what you would be doing as a plastic surgeon. Are you
Yeah, I mean,
enjoying it?
I love it. I mean, it's been a great journey. When they always tell you in training, like what you learn in training, you'll probably end up doing something completely different in your practice, and that is true to some degree. But
Just like, yeah.
the cool part is you use all those principles that you learned in your training. A lot of my understanding of implant removal, muscle reconstruction, the techniques all evolved from my breast cancer reconstruction training. And I have the advantage, and I'm fortunate to have this of being a general surgeon and a plastic surgeon. So we used to do mastectomy, so I understand the breast physiology itself. And then, I trained to do reconstruction. So you get the best of both worlds and you apply that to your practice. And it's been really interesting and fun. And I love it. I think our whole team is really invested in it. We all really kind of believe in what we're doing, and that's part of the fun too.
Yeah, I think I agree. We're all enjoying it very much. We love our patients, and just it's a great practice.
Yeah,
And we all
yeah,
love
that's
working for you. You're an amazing surgeon, so I know you give your heart, you pour your heart into what you do. So I
yeah.
think
No, it takes
we
a
feel,
village, right?
yeah, we definitely feel it in the practice.
Yeah. No, it's been it's really meaningful work. It's not work actually.
Yeah.
It's we don't feel like we're coming to work. So it's always fun to treat patients in a manner that it's not like, oh my God, I gotta go see. Like we enjoy it. So yeah, no,
Yeah, I told
thank
a
you for my
patient
team.
recently. I said, I think if we hit the lottery, maybe we'd work one day less, but we're still.
We wouldn't work on
Yeah.
Saturdays.
Yeah. Yeah. No more Fridays. No more Fridays. That's for sure. Uh, okay, so let's see. I think we're almost done. Unless anybody has any other questions. Explant surgery 1029. Okay, very nice.
Coming up, coming up.
Just tuning in. So, Ms. Lee, we will repost the live, and we usually on my highlights I have them under patients want to know. I have a question. Go ahead. I started your schedule, but can't wait to ask a million questions. You can ask 100, not a million. um, you can ask. We still have a few minutes, so if you have any questions right now, you can ask. Bianca, when transferring. Mm-hmm.
with explant, do you lift the muscle as well or just the tissue? Just the tissue. The muscle has to stay in its anatomic position. Can you add fat to a breast that has a mastectomy? It's challenging. You know, you need breast tissue to inject fat into. So if someone's had a reconstruction with their own tissue, like abdominal tissue, with their buttock tissue, or they've done a tissue transplant, you can inject that fat into that tissue and eliminate the need for an implant. Um, there are some docs that are doing serial fat transfers in mastectomy patients. Sometimes you'll need 4 or 5 surgeries to get some type of a breast mound, but that's also an option. But I don't do that particular surgery.
Is it best to maintain fitness levels? You'd have post-op or maintain fat.
Yeah, so usually I suggest for the first 3 months not doing any type of cardio after a fat transfer. So you can do things like core exercise strengthening. We encourage abdominal exercises, squats, leg exercises. You can even, once you get to that 6 week mark, you can start doing some upper body strengthening exercises. But I try to avoid cardio so that you're not burning any of that fat that's trying to survive.
You know, the patients that are asking me about fees, we just don't want to get into the fee schedule here, but go ahead and send me a message and I'll be happy to leave me your phone number and we can discuss your procedure at length and I can give you fees.
Yeah. Oh, so Misty, is it best to maintain fitness level you had post or maintain fat? Yeah, I mean, the goal, you know, obviously if you're, and we touched up on this, but if you maintain your natural happy weight, so don't put on weight before a fat transfer. And so, yeah, if you're happy where you are and your fitness levels are pretty good, I would say just keep that going. You'll be fine.
Scar treatments like laser Morpheus?
Yeah, if it's indicated, you know, laser for certain scar management, pigmentation. Morpheus, I would caution using against it on scars early on. Later on, I mean, I don't have a Morpheus machine yet, but I have colleagues that use it sometimes on scarring later in the process, and it can help. But again, you have to really assess the nature of the scar, the time frame at which it's been healing in, and how it's been healing before you make any external insults on it.
Do you sit the patients up during surgery to make
Oh
sure
yeah,
the breast is nice?
yeah.
Every
Sometimes,
time,
quite a few times.
yeah.
Sometimes, yeah, I
Sometimes
say
we
up and
chime
down,
in
up and
there and
down,
say,
up and
yes,
down.
those look great, or yes.
Yeah,
Awesome.
yeah.
Does fat transfer work for tubular breasts?
Yeah, it can improve tubular breasts, absolutely. If you don't have implants or never had a history of implants and you have tubular breasts, there are ways to improve tubular breasts with fat transfer. Sometimes you need 2 or 3 rounds to really get your desired goal. Depends on the degree of tuberosity.
There should be more awareness being done about the consequences of implants. I
Definitely, I
agree.
think,
What
yeah,
do you
no, it's out there. You know,
It's getting better.
interestingly,
They have improved.
they have improved. I think more surgeons are educating patients. They're required to now by the FDA. There's checklists alerting patients of it. So I think the education part, it's getting better and better. It's going to take a while to completely, I think, get standardized across the board, but I think it's getting better for sure.
You know, there was a question someone asked yesterday, before I forget, on the buttock implants. If the patient decides to just leave them in, what have you noticed throughout the years? Like, are they sagging? Are they causing
Yeah, yeah. No, they with all as all gravity always wins. So the implants do drop over time. It can create that kind of pulling effect. And some patients comment on how they always have to wear supportive garments to kind of keep things
Yeah.
in place.
Mm-hmm. So they dress
Um,
differently to
yeah,
accommodate.
yeah, and then as you age, you get some muscle atrophy from the implants. So that atrophy means the muscle thins out, you lose some fatty pockets, your skin gets looser, so everything works against you. So everything just kind of starts dragging down a little bit, and then you start kind of seeing the effects of that, and that's when you want to think about getting them out and maybe doing some reconstruction.
What's a healthy iron level for surgery? What are we looking for? That's a
Um,
good one. The lab work, what exactly are we looking for?
Yeah, I mean, you want to have there, it just depends on the lab because each lab, like Quest and LabCorp, they all have their own normal values. So as long as you're within that normal range, if you have like an iron deficiency anemia, some patients are already being treated because it's been known as a pre-existing issue. So they'll be taking iron supplements or they'll get iron infusions, which we encourage you to continue throughout the process. The number that will really affect your surgery, whether it's from iron deficiency or whatnot, is your hemoglobin number. So for us to safely move forward with the procedure, the hemoglobin has to be 10 or above. And so if you have an iron deficiency and your iron levels are low and your hemoglobin is still low, then it's best to optimize yourself. So you see your primary care doctor or whoever is managing iron levels, discuss best strategies to improve your iron stores and recheck your hemoglobin. And once you get to that number above 10, then it's safe to proceed with surgery.
Anxiety medication, that's a big one. So many patients take anxiety medication. Can they take it up to the day of,
Yeah.
the evening of? Why should they stop?
I mean, you can take it the night of the surgery, and we will review that, and my anesthesia team will also make recommendations. But in general, we're okay with you taking it the night of surgery, but definitely not the morning of surgery, because we do not want any of those medications interfering with the anesthesia.
Uh, I've been hearing there are many implants out there you never have to replace. Is that true?
I haven't heard of an implant that doesn't need to be replaced.
Mm.
I mean, they're always coming out with new implant types and dual fill saline silicone. But again,
Or
these
new
are all,
advertising for it, probably.
yeah, they're all man-made devices, so they're all going to have a shelf life
Mhm.
with complications. Shell cracking, ruptures, leaking. They're always going to have some issues. So I don't think there's going to be an implant out there that's going to be like, oh, this lasts forever. They're always going to have wear and tear and mechanical issues.
Do you explant implants in breasts that have had mastectomy and reconstruction with implants?
I do the explant and a flat closure, but I do not put implants back in. So if a patient comes to me requesting that particular procedure, I will offer them an explant, muscle repair, capsulectomy, and removing the excess skin for a flat closure. And then the
Mhm.
option they have after that is to use an external prosthesis to create a breast mound. If that is not an attractive offer, I have colleagues that I refer them to consider doing things like implant removal and free tissue transfer.
Mhm.
So those microsurgery cases where you have to do it in probably a hospital-based setting where you transfer tissue from your abdomen or legs or wherever they think is a good donor site to reconstruct the breast. So I'll refer them to those docs to my colleagues to have a discussion on whether it's a good option for them.
Daisy's sister. I've had circulation problems, my legs, swollen ankles. Should I wear support stockings during surgery?
Yes, so we
Yeah,
already put on some
we
compression
give those
devices,
to you.
but
Yeah. Hmm.
yeah, but if your legs are swollen and ankles, one, I mean, just make sure you've had an ultrasound done before to find out the cause of your swollen legs. So, we don't want to have issues with blood clots afterwards and increased swelling. So we just have to make sure that's been ruled out. And then yeah, compression, leg elevation, and walking are going to be your best friends after the surgery
Why do patients have to walk after surgery? I know patients
to
have.
prevent blood clots.
Mhm.
The main thing is to prevent blood clots, and also when you have surgery, your lungs, they just kind of shrink a little bit because you're not taking those deep breaths. So walking helps to kind of re-expand those
Mhm.
lungs, and the main thing is it helps prevent blood clots. So we want you up and moving around.
Hemoglobin is lower than 10. So will surgery be postponed until the numbers go up?
Yeah, yeah. And the one thing we also remind patients is when you're doing your blood draws for your tests, for your preoperative appointments or in general, But just make sure you're not on your period or your cycle because that will create a really low level as well. So we'll see sometimes hemoglobins of 8 and we'll be like, okay, what's going on? And then we'll ask the patient, oh, were you on your cycle or your period? Like, yeah. And if you have heavy menstrual cycles, it's going to create a lower. So then we'll have them recheck it later on and it usually perks back up to a good number.
Okay. Oregano oil, is it safe to take instead of antibiotics? That's a good question.
Yeah, I'm all about natural alternatives. So I think oregano oil is fine. For full disclosure, we do give IV antibiotics, which we are required to during the surgery.
Mhm.
It's part of our safety requirements to prevent surgical site infection. And then I wash the whole breast pocket with a lot of antibiotic solution. So you're protected to that degree, and then oregano oil is fine afterwards. If you do show signs of an infection or something looks like it's kind of festering in there, then we will definitely switch gears and have you go on oral antibiotics, or we'll give you some shots in the clinic.
We appreciate it. Thank you so much, Mr. Yeah, we enjoy it, but we know that it's necessary as well. Jaylee is chiming in. Jaylee, we're going to record you talking about the patient during recovery, so don't worry. We got you.
Yes, walking helps with
Yes,
soreness and
it
stiffness
does.
for sure. Just to clarify, if already taken iron, just continue until right before surgery. Yeah, continue. Not a problem. And if you take iron and you have issues with constipation, then I would continue your bowel regimen as well so that you don't get constipated after the surgery.
Patients on aspirin therapy.
Yeah, we need you to stop the aspirin before the surgery because the risk of bleeding is real. And it just depends. I mean, if you have had, say, a cardiac stent or you have some sort of a neuro, then for our practices, because we're an outpatient office-based surgery, we don't operate on patients who have had any type of cardiac stent because the classification system gets higher from a risk standpoint. And so by law, we can't do those cases. And so those cases can be done in a hospital-based setting.
Mm-hmm.
You just have to find a surgeon.
Which we don't do.
We don't do hospital-based cases, yeah. Miss B84, it takes 1 full year to see your final results. You'll see what you want to see at 3 months. Everything is going to shape nicely, but the breast, it's amazing how the breast skin and the tissue continues to mold. So I usually say like at 1 year, you're going to see kind of the ultimate final result.
Okay. Let's see. Okay, so I think we're almost done. Oh, this is one. How do I know if I definitely need a lift? And can we wait to find out the day of surgery? So we have so many patients flying in for the procedure. Although, patients are asked to submit the pictures and you view all of the pictures and review everything. Can they wait and see what's needed?
No, I have certain criteria that makes patients a good candidate for a lift or not. But yeah, definitely. I mean, if you send pictures, we can give you a good sense of whether a lifter is good or not. Sometimes patients are in the gray zone, so like we have to just kind of get a feel for the tissue, and we will keep you as a explant with the lift just to block out that time and have the equipment ready. But if I see you and I don't think you need a lift, then I'll definitely tell you just to explant only. And we've done that so many times, and that's totally fine too.
Mm-hmm. Do all breasts fluff back up?
Yeah, I mean, we call it the fluff fairy. Is basically when you do the surgery, everything's swollen, right? So your muscles swollen, and then you don't have the implant, so you have that kind of dip, and your breasts are swollen, so everything is wavy. And as the weeks and months go by, the swelling goes down, the skin tightens up, the breasts start forming and shaping. So they call it the fluffing period, but it's just more swelling reduction and the breast normalizing. So everyone goes through that phase.
If we're a patient who naturally does not gain or lose fat in the upper body, is that a challenge or a bonus to fat transfer?
That's a bonus. bonus. Yeah. Yeah. Patients will tell us that, when they lose weight, the first place it goes is from their breast. So that tells you something about the morphology of the breast in that area. So, but if you're like, yeah, I lose weight, but my breasts stay the same size, then that's very advantageous to you.
Mhm.
Yeah. So, with you, Miss Lee, if your fat is held in your lower body, thighs, legs, and back, then that allows us to get good fat pockets from you. And then, yeah, if your breasts tend to withhold fat, then that definitely works to your advantage. Yeah, you'll be able to wear normal bras again. By 3 months, as a general guideline, you'll be able to wear whatever type of bra you want. You can go braless, you can wear underwire bra, you can
Yeah,
wear
yeah, and
bralettes.
underwear, yeah, probably at 3 months you'll stop feeling uncomfortable
Right.
with the underwear, but you
Yeah.
can.
Yeah.
I
And then depending on the lift, we'll suggest certain bras to you. So we have certain tricks we do with the
Mhm.
underwire bra for lollipop lifts, now with the periareolar lift or the donut lift. So we'll guide you through that process on what bras to use.
More benefit for lift of this if the scar is longer than the usual anchor scar. I
It
guess maybe
just depends.
extended lift.
Yeah, it just depends on how much loose skin you have. So um, this length of the scar is dictated by the amount of extra skin that you have. So if you don't have a ton of loose skin and you form nicely with a nice little scar that's hidden underneath your breast, well, great. But if you have a ton of loose skin going from the middle, especially over here, if you have loose skin on the sides, then you have to elongate the scar. Um, if you say, well, I don't want that long scar, then you're going to have to be okay accepting a little bit of loose skin in those areas, which cosmetically you have to decide, which is acceptable, scarring or loose skin. So that kind of dictates how long the scar is. But for me in general, I like to keep the scars confined to the tan lines or the bikini line. So I'll make a really good effort to limit that scar. Some patients already come in with pre-existing scars that are really long, and we just we
Yeah.
take advantage of those, and we recreate scars that are similar. But once you have that scarring there, it's yours to keep.
Is there a waiting period for scar treatments that you recommend?
I always we start doing the scar massaging 2 to 3 weeks after the surgery. And so that's what we do for our scar management. We'll do massaging with natural oils, and then see how they heal. So if they're healing and they're heading in the right direction, we'll continue that. If you need adjunct therapies like say lasers or things like that, then we'll walk you through based on how your scars are healing.
Mhm.
So it's very individualized.
Mhm. Natural vitamin E oil or Mederma?
Yeah, vitamin E, coconut oil are the most popular ones. Mederma oil, so Mederma without silicone, no silicone. Mederma oil itself with SPF is a great option.
So
And
silicone
then as you move,
question, but why not silicone?
I mean, we're taking silicone
Right.
products out, so we don't want to put them back on the skin. Some patients do have they've used silicone in the past on say C-section scars or tummy tuck incisions and had good results if they have a history of
Or
hypertrophic
maybe
thickened
breast.
scars.
Uh-huh.
Yeah, so those patients, might sometimes, because we know how their scarring is, we might bite the bullet and be okay, you've had a history with it, let's use it for a temporary short period of time. But other than that, if the castor oil, yeah, absolutely, castor oil, vitamin E, coconut, if those are working well, then that's all you need.
Perfect. This is someone asked me yesterday, so how quickly can the actual process go? They have I have a patient calling me and she's going to be coming in from really far and she wants to have a procedure. Like she arrives at 10 a.m. Can they go right into surgery or should they wait a day?
I would wait a day. When you're traveling, you get dehydrated, you've been sitting, your blood is
Mhm.
stagnant. All these are setups for issues. And these are elective surgeries. We don't want issues. So I would say, land, get settled in, get to know your environment, your hotel, get comfortable, unpack, get
Right.
everything set up so you're comfortable, walk around, get
Yeah.
hydrated, get
Yeah, I think
familiar
that's
with your.
really important when you arrive from the surgery to make sure that the bed, everything is comfortable, there's food in the fridge, everything you need because you'll be pretty sleepy and a little bit out of it.
Yeah.
Uh-huh.
Um, Arnica, I think, is safe before surgery. I have not seen any. Most of our patients take arnica, and we don't see any issues with bleeding. If it's arnica combined with something else like fish oils, or if you're having a combination pill, sometimes that'll increase your risk of bleeding. But arnica pill by in itself, I've not had issues with bleeding.
Yeah. And the arnica start a couple of days before.
Yeah, I mean, in general, you can start 3 days before. I
Mhm.
don't mind even if you want to start it. If you say like our patient was going to Napa,
Mhm.
or if you have like any increased risk of like say oozing with certain supplements, you can take it a week before too. It's not, there's no harm in doing that.
Do you bring capsule cavity back in for internal lift? Not understanding that question.
Um, so I mean, once the capsule comes out, you just have your tissue there. So you use whatever tissue you have to mold it, and it's kind of like, for lack of a like origami, you're restructuring things and pushing things in for the internal lift, so to speak. And I use sutures, so I, especially with like certain lifts, I'll use sutures to reconstruct the breast pillars and try and kind of pull things up to fill in those spaces that the implant used to live in.
2 hours home after surgery, drive time.
Yeah, I I mean, I don't necessarily recommend that, just because it's one, it's a long drive. Two, if there's an issue, God forbid you have a hematoma or some
Yeah,
issue, we don't
we need
want
to see
you.
them the next day, so it doesn't make sense.
Yeah,
To,
so I know it's probably comfortable being in your own bed, but I think it's safer to be close to the surgery center within, say we say 15, 20 minutes after the surgery, in case there's an issue, so we're able to tackle it immediately. But if you're 2 hours away and something happens, it might not be safe for you to drive 2 hours to come see me, so you might have to manage it locally, and
yeah,
that's usually not the best
right.
situation.
What kind of sutures do you use?
I use all dissolving sutures. I have some unique sutures that I use that are part of my armamentarium for my breast reconstruction days that help. I call it an internal underwire. So I use these unique sutures for reconstructing the bottom portion of the breast. Those dissolve over 6 to 8 months, so it really maintains the integrity of the breast on the bottom. And then in the rest of the tissue, I use dissolving sutures that go away after 2 to 3 months.
Okay, so they vary.
Yeah, yeah.
Do you know prior to surgery what sutures you'll use? I know patients have asked me that.
Most of the time, yeah, based off of the lift. But we don't usually, once we do the surgery, then we might swerve and use different type of sutures based on the tissue. So it's individualized, but in general, thick reconstruction suture for the bottom, delicate sutures for the nipple and the vertical.
And then the taping after the procedure, how important is it?
Well, we like to do, if the tissue is raw, then we won't tape it. Then we'll cover it with some antibiotic ointment and non-stick gauze. But if the skin looks perfect, then we'll tape it to keep it protected for another 7 to 10 days. And then once that raw factor is kind of resolved, then we'll start the massaging.
So do you have a specific technique? What sets you apart from other explant surgeons?
Yeah, I think that's multifactorial. I think the one, it's not just the surgery. So I'll just dive on a broad. So with our anesthesia, we have a very unique protocol, I think, with preventing issues pre-op and post-op, with not using any narcotics and the type of anesthetics we use. So we actually have patients calling in if they're having a procedure for some other reason somewhere else, and they're like, "Hey, what was that medication you gave me? I felt great after the surgery." So that's one unique part. Then from the surgical part, I think my expertise with breast cancer reconstruction, general surgery or mastectomies, those things tying together to make me more equipped during the surgery. And then with trauma surgery, I'm able to identify issues, complications, and fix those immediately. So those things make me better equipped to do it. I think from an aesthetic standpoint, my goal is always to create the least amount of scarring. So I've really honed in on my skills to try and achieve these surgeries with minimal scarring, meaning length of scarring, or trying to do the techniques with smaller incisions. So I think that sets me apart.
Yeah.
And then I think our post-operative protocol is really, we listen to feedback. We've learned a lot from our patients on how to improve it, how to make the experience better. We love patients who are happy, but if patients are not satisfied, I think those patients give us valuable insight on how to improve our services practices, and we're very open to it. And our team has been really open to those kind of things.
I think also the fact that we believe in the patients, we believe what the patients are feeling is real.
Yeah.
We believe the heal is real for sure.
Yeah. But yeah, a lot of patients talk about bruising and stuff. Everything we do, bruising is kind of like something that will really delay your healing. So we do things with surgical techniques we don't want bloody feels. We try to minimize bleeding. We take our time injecting numbing solution. So it's a time intensive process, but it works really well and the outcomes have been really good.
That's great. Many compliments to you, Dr. Dove. Patients are.
Thank you.
Your character, your honesty, your results. Patients just love you. So.
Yeah, I appreciate it. I love you all guys back too. It's been amazing.
Yeah, we have the best patients. I feel only the best patients gravitate towards us. Love them. Do you
recommend MLD? By MLD, are you referring to manual lymphatic drainage? And if that's MLD, then sometimes I do. If the implants are really stuck in the armpit and there's swelling in the upper armpits, and then I'll recommend you go see a lymphatic drainage specialist. And then all our patients will teach you how to manually drain your pectoralis muscle on the top of the muscle. That's part of our protocol.
But is it absolutely necessary? Does every patient need lymphatic drainage massage?
For the pec muscle, yes. Mm-hmm. For arms, armpit region, side of the chest wall, not everyone, case by case.
Okay, thank you. Okay.
Do I have a lot of revisions? I think revisions are they come with the territory, and that, we do revisions for irregular scarring, scar contracture. If there's a little bit of loose skin, we do those kind of revisions. So yeah, I have revisions. If someone has say an issue with wound healing and they don't like the way things have scarred, we revise it. So yeah, we do revisions. The nice part is,
how long should they wait?
I usually like to wait for a year. In general, some patients who have little loose skin here or there and they want it done at 6 months, I'll evaluate and do it at 6 months. And then, the one thing that is not considered revision, but if patients are unhappy with how their breasts have settled, meaning they have these kind of concavities, which can happen with large, huge implants and not much breast tissue, then we start having that discussion about fat transfer as a formal procedure to volumize the breasts.
Okay. Anything to be done to tighten the skin after explant?
Yeah, so the natural thing we talked about was castor oil and castor oil packs to help tighten it, work on the pec muscle to help tighten the skin around it, and then we individually look at the skin and see if things like Morpheus or any type of laser technology helps tighten the skin externally.
Okay. All right. I think we passed just a little bit. It's almost an hour and a half, so it's awesome.
Wow.
I see we definitely needed to do this. When can I sleep on my side after explant? Great question.
Probably you can start cheating and leaning in 2 to 3 weeks after the surgery. You're going to get sore on the side that you sleep on, and we will clear you for that. You don't want to put too much pressure on the side of the breast because, your sutures are healing. So we usually say if you're starting to lean in on your side, get a soft pillow and slowly lean on your side. See how it feels in the morning. If you're sore, put some ice packs on that area. Take some ibuprofen. You can massage the area, and then try the other side. But if you're having issues with healing or you're still sore, then just lay flat until we clear you for side sleeping.
Okay, I'm getting messages patients haven't seen. Okay, I'll just send some patients the videos. How long for ice packs?
Ice packs, so we will definitely recommend it for the first 2 weeks while that muscle is swollen, and then then you can use it as needed. Once you start working out and moving a little bit more, you'll get sore. So ice packs on the top, making sure it's not touching your nipple, and then ice packs on the sides where the drains used to live are two of the good spots to put it.
All right, one more question, and I think it's really important, and it's a sensitive subject, but what about sex after surgery?
Yeah.
How soon? And
Yeah, usually, sorry, husbands, but 4 to 6 weeks is probably a safe time to wait to engage in physical activity from that standpoint. You can do, as long as you're not doing motions that are shaking the breasts or causing a lot of swelling in those areas. Definitely no grabbing or anything for 4 to 6 weeks. So I would suggest waiting for 4 to 6 weeks before engaging in those activities.
perfect. Thank you. I know patients ask this so much, but okay. All right, everybody. Well, thank you so much. This was fun.
Yeah, thank you. Thanks for all the questions, the nice comments.
Yes,
Really nice
thank
to
you
hear.
all. Thank you for following us. Thank you for believing in us. And we've had patients for years that they had surgery years ago and they're still here. So thank you guys. You are all amazing, and you are the reason we do what we do, and the reason why we love it.
Yep. Yeah. Looking forward to helping everyone out there, and for all of you who have gone through the process, I really hope you guys are feeling great and amazing. And thanks for sharing your stories and helping other women try and go through the
Yeah.
process. So appreciate
Thank you
that.
for your feedback.
Yeah.
Thank you. Okay, everybody. Send me a message if you want me to reach back out to you. Okay.
See you in the office, B.
See
All right.
you. See you later.